pancreas cancer, it's really hard to examine your pancreas cancer. Oftentimes when I see patients in clinic, I mean, I press on their belly, but I can't really feel their pancreas through their abdominal wall. So it's a hard cancer to detect. And oftentimes you have to have symptoms that end up causing people to get diagnosed with cancer. So that's why we kind of see this rise, is because all the other cancers we're getting pretty good at diagnosing at an early stage, but pancreas cancer we're still not very good at doing that. Okay, so the pancreas does two things. It helps you digest foods, like this lovely dinner that you just had from Mariano's. It's particularly good at digesting fats. So when people start to have problems with their pancreas, they can get it's a very distinct problem, which is a greasy diarrhea, a really fatty diarrhea. You can even see oil droplets in the water. It's very, very distinct. The other thing the pancreas does is it helps you regulate your blood sugars. And so I think many people have heard of diabetes, right? So diabetes is frequently associated with problems with pancreas and insulin sensitivity. In pancreatic cancer, what we often see is that people develop diabetes in the setting of actually some weight loss. So in general, if you went to your primary care doctor and they said, oh boy, you know, your blood sugars, your hemoglobin A1C, it looks like it's going up, you need to, usually they tell you, I hear this all the time, lose weight, exercise more, right? That's what your doctor's always going to tell you. Lose weight and exercise more, and your blood sugars are going to come down. Because your blood sugars go in the same way as your weight. But in pancreas cancer, people are losing weight because they have cancer, but their blood sugars are going up. So it's the opposite, it's paradoxical. And that's because the cancer itself is driving the diabetes. It's actually, it makes an insulin-like growth factor and it drives the diabetes. So you see oftentimes within 2 years of diagnosis, people have developed diabetes before they're diagnosed with pancreas cancer. Okay, often in the setting of weight loss. All right. So we talked a little bit about the challenges in diagnosis. Yep.
Okay, with that whole weight loss thing, how is it drastic weight loss?
Yeah. So the question, in case you didn't hear it, was how much of a weight loss? So, you know, a 5-10 pound weight loss, I think we often see that from summer to winter and holidays, that's okay. But usually we're talking about 30, 40, 50 pound weight loss.
No.
Yeah. So if you lose that much weight, your blood sugars should be looking pretty good. So if they're getting worse, there's something wrong. Okay. Is that to answer your question? Okay. Any other questions? All right. So the pancreas is an organ that sits way in the back of your body. So it's hard to see on this, but here's your spine, and your pancreas sits right on top of it. And so because it's so far back, it's hard, again, to examine it on physical exam. You know, it's like, it's hard to just see it. So we have to use some imaging or some other techniques to see it. And then the symptoms that people have can be really vague. You know, it's just, something just doesn't feel right on the inside. They may have a little abdominal pain after they eat, some cramping, some bloating, but it's not something that we can say, aha, you have this and therefore you must have pancreas cancer. It's a very vague symptom. So, and this is really small. I apologize for this, but what this says here, and it's actually on, I've made a little bit of some handouts for you guys that you can take with you, just some like a cheat sheet of facts for pancreas cancer. But that top purple box says that pancreatic cancer is especially high in males. It's a little bit higher in males than females, in blacks versus whites, and in older people, over 65. Okay, and then the risk factors, a lot of the risk factors are kind of shown over here.
Did you say pancreas cancer is higher in males than females?
Yes, slightly higher in males. And then, you know, in terms of the racial groups, the highest rates of pancreas cancer actually are in the Black communities. And then older people tend to have pancreas cancer. So the average age of diagnosis for pancreas cancer is around 70, 72.
Is that
Say that again.
I think it's something that he has a race of people that's causing that.
well, see, I was going the same where you're going. Yeah, I was going the same thing.
There's a cure for everything.
Something that they've been doing in the past that caused that?
Yeah, so the question was, is there something maybe dietary or environmental question. You know, in Wisconsin, we have some of the highest rates of pancreas cancer in the country.
Was that right?
Is that maybe alcohol related? Alcohol?
Yeah, so there's some hotspots. If you go to the Wisconsin state, it's like the CDC for the state of Wisconsin, it'll give you the areas of cancer within the state. And you can see that there's some hotspots for pancreas cancer. One of them is along Lake Michigan, and
Well,
the
they
Ponce
should have some
Valley.
kind of idea of what's the cause, you know, if it's hotspots all over the area.
Yeah, I think that's something we're very interested in learning more about and trying to study. We don't have an answer right
Okay.
now. So the things that people always connect, this thing that is most commonly associated with pancreas cancer is smoking. So, and again, this is what your doctor will tell you. The first thing you can do to mitigate your risk of pancreas cancer is to not smoke. Other things that are associated with good for you. It's not easy to do. The other things that you can do are limit your alcohol intake. So that's one thing. And then the other thing is, I think it's been associated with obesity as well. So we're gonna go on. So the symptoms, and again, we have this little cheat sheet here. There's these little cartoons which I thought were kind of cute, talking about the different symptoms people have for pancreas cancer. So one of them, the first one that's most classically talked about is jaundice. So do you guys know what jaundice is? Yep, when you turn yellow and your eyes turn yellow, and you have a buildup of bile in your liver. And the reason why that happens is because your liver makes bile, and that bile has to go through your pancreas to get into your intestines. So it's not a problem with your liver, it's not a problem with your bile ducts. It's just that bile duct has to go through the pancreas to get into your intestines.
It's not the pancreas, it's not on its job.
Yep, so if there's a blockage in your pancreas, blocking that bile duct, you can become jaundice. So classically, we often talk about it being just painless jaundice. Sometimes people get jaundice because they have gallstones or other things, and those tend to hurt. And so that's painful jaundice, but for pancreas cancer, it's usually a painless jaundice that kind of comes around. All of a sudden, you haven't seen, your mom or your dad in a couple of weeks, and you look at them, and you're like, you look a little yellow. So that's the jaundice that they're talking about. The other things they talk about here, again, are a little bit, nondescript. So they talk about abdominal pain, but again, that's kind of vague. Indigestion, and that's because when you don't digest those fats well, like I was saying, you can get a lot of gas, and you pass a lot of gas, and you get a lot of cramping. The bowel change I talked about, so that's the diarrhea. You can get some back pain, especially because I told you the pancreas lives way in your back. So if you get a tumor there that's growing large, it may be growing backwards instead of forwards, and it can cause some back pain, and then weight loss. Okay. The other thing I wanted to mention here is that, when I studied in medical school, people said that, pancreas cancer was not hereditary. But now we know actually about 10 to 15% of pancreas cancers can be hereditary. So how you would kind of be worried that there might be a pancreas cancer syndrome in your family is if you had more than 2 people with pancreas cancer in your family. That's a little unusual because it's a rare tumor. I told you that there's only 45,000 cases in the United States a year. So if 2 of them are in your family, that's kind of unusual. So 2 first-degree relatives or 3 any-degree relatives in your family with pancreas cancer, you actually would qualify for screening. So right now, we screen for breast cancer and colon cancer, lung cancer even. We don't screen the general population for pancreas cancer because it's so rare. But if you have a strong family history, you would qualify for screening. So and what that entitles is just basically an MRI of your pancreas every year, just like women going for M&Ms every year. Same thing with an MRI of your pancreas.
Dr. Sai?
Yep.
So what then would be considered a strong family history? So if I have one person in my family, like an immediate family member with pancreatic cancer, would I qualify for screening?
That is a great question. So I talked about having 2 family members. So if you have 2 family members, you kind of qualify for screening, definitely 3 family members. If you have 1 family member and your family actually has a known kind of genetic mutation that's passed down in your family, you may be eligible for screening as well. The most common example of this is, have you guys heard of BRCA or BRCA? Yeah. You guys know who Angelina Jolie was? Yeah. You know she had breast cancer? Yeah. No. Yeah. You need to read people a little bit.
Okay.
So Angelina Jolie, very famous movie star, had breast cancer, and when she was diagnosed with breast cancer, she underwent genetic testing. It turns out she has this mutation that she inherited in her family called BRCA2. It's a mutation associated with breast cancer. Probably about 60% of women who have that mutation will develop breast cancer in their lifetime. That's huge. Like in the general population, it's around 11% lifetime risk. With this mutation, it's 60%. BRCA2 is also the most common gene associated with hereditary pancreas cancer. So if you happen to know in your family that you have this gene that's called BRCA2, and you have one family member with pancreas cancer, you qualify for screening. Go ahead, sir.
I don't wanna say, I must have missed something.
Yeah.
When you were talking about the screening. I thought, I heard you say earlier that it was hard to detect pancreas cancer.
Yes.
So what's the purpose of going to get screened if they can't detect it?
Yeah, that's a great question. It's exactly why we don't screen the general population, because, you know, to screen all of the United States, it takes a lot of money to screen everybody. And you're screening for a cancer that's relatively rare, so the yield of getting a test on everyone is going to be low. To find it, so what we do to find it for screening is we do an MRI. So it's a very high quality MRI that just looks at the pancreas. And just like for breast cancer, colon cancer, when they go in, what they're looking for is anatomic change. You know, they look for calcifications on the breast, you know, the breast mammogram. They look for a polyp, or they see a polyp on the colonoscopy. In the pancreas, what we look for are cysts or masses that usually aren't there. And those are the things that we work out. Does that answer your question?
Well, yeah, because it sounds like it's gonna be over a period of time, not just one time.
Yes, so the purpose of screening, just like for everyone, I hope everyone is kind of getting up to date with their mammograms and their colonoscopies, but the purpose of screening is to catch a cancer before it even occurs.
Right.
Yeah, it's to catch a precancerous lesion. Yeah. These are great questions.
So, Dr. Saad,
Yeah.
I'm sorry, my last one.
Yeah.
My last question then. So I just want to make sure I clearly understand. So then, if we have at least one person in our immediate family that has suffered from this, because it's not a regular screening that you do when you go to your doctor and you get a physical,
Yeah.
they're not going to automatically check.
No.
Unless you say, I have someone in my immediate family that has
Exactly.
this.
That's a really great point. Yep. So your family history, when you talk to your family doctor and, you know, you're telling them their history, what happens in your family is really, really important. You know, we inherit all of our genes from our mom and our dad. And so if there's a strong family history of cancer in your family, that's going to be very helpful for your physician to understand how risky it may be for you to develop a cancer as well. It's a really great point. Okay.
Another question?
Yeah. Oh, yeah.
What if you don't qualify for the screening, but you suspect that someone in your family does have this, and these things that you described a little bit, or
Yeah.
especially the drastic weight loss, like, or this might be a case where somebody has pancreatic cancer.
Yeah, so I think those are great things to have conversations with your primary care doctor that's taking care of, you know, your family or that individual. If, you know, if there's a series of symptoms that you're seeing and, you know, with or without a family history, that's why your primary care doctor is there. But the one thing I could say is for sure, if you develop diabetes in the setting of weight loss, that is not normal. That should be worked up as pancreas cancer until proven otherwise.
Thank you.
Yeah.
BRCA2,
Yeah.
how would you know?
You would not
Is there
know.
no screening for that at all?
There is not. You would not. So the question was, how would you know if you had BRCA2? Or there's actually 28 different other genes that are associated with pancreas cancer. The only way you would know is from your family. that if you had a strong family history of breast cancer, colon cancer, melanoma, these kinds of cancers that, like every generation, you're getting these cancers,
So
you should be
someone in our
tested.
family would have probably been tested for that.
Well, they may not have been, yeah, so I think it's always worthwhile bringing it up to your physician, because sometimes it's amazing, you can see families with every generation having cancer and nobody's been tested. So you could be like the important person that actually, gets tested and then informs everyone else in the family based on their testing. Yeah. These are great questions. You guys aren't falling asleep after the class, I love it. Yes.
Normally when they go to the hospital, I know they take several vials of blood. I've seen them take a lot from me and they can tell pretty much what's wrong with my blood. Is that true?
Well, it's not perfect. So the question was, will a blood test tell you what's going on? Yeah, so the majority of people with pancreas cancer, the only thing that we would pick up from the blood test would probably be the jaundice, that there would be a buildup of bilirubin. But all these other symptoms are not necessarily associated with the blood test. That being said, what I haven't told you guys is we're trying really hard to develop a blood test to look for different cancers. It's something that the NIH has been working very hard on, specifically in pancreas cancer. So there are currently at least 4 or 5 different blood tests being tested to see if they're good enough to screen and detect cancers just by a blood test. We're not quite there yet, but I think in the next 5 years we will be.
Now, doing the chemo, local chemo radiation kill most of those cancer in the body to detect early on.
Yeah, so we're getting on to, so the next question was, won't chemo and radiation treat this cancer? And we'll get to that maybe in a little bit later in the talk. Okay, any other questions? You guys hearing me okay still?
Yeah.
Okay. Oh, sorry. Oh, yeah, sorry. So this was my screen about cancer in general. So we think that how cancers develop is you take a normal cell and then it starts over time as you age. You can have some mutations that your cells, your body, by accident, there's mutations that are acquired, and then those mutations build up, and more mutations come, and then you develop into cancer. So in the hereditary point, when you have a BRCA, you already are predisposed. You already have one mutation. You don't have to build up into a mutation. You have one when you're starting, and so it accelerates that pathway to developing cancer. Okay. All right. So let's say you're worried about your family member, and you say, boy, maybe somebody has pancreas cancer. What should you do? So there's the first thing I would tell someone to do is get a CT scan, one of those CAT scans, because again, I can't tell by pushing on someone's abdomen if they have a pancreas tumor, but a CT scan can show me a window into the inside, so I can see if there's anything anatomically wrong with the pancreas. And so what you see here is, this is a CT scan. The patient's lying on their back. This is the right side, and this is the left side, and this is front and back. So they're lying down like this, okay? And so what we're seeing, like over here is the liver and the gallbladder. Here's the spine, there are the kidneys. Here's the pancreas back here, and here's the mass. See that mass? It's a little bit hard to see, but there's a mass sitting right there, and what we call the next to the pancreas. So you can see that if I were trying to push down, right, I have quite a ways to go, and I might not be able to feel that mass because there's a lot of normal skin and tissue and muscle. And I couldn't push either on the sides either to feel it. So it's something that we have to see by the CT scan. So then if we wanted to know if there was a cancer in that mass, we would do an endoscopy. So I tell people this is like a reverse colonoscopy. You go to sleep, and then you get a camera that goes down through your throat, down into your esophagus, into your stomach here. And it's a special scope that has a little ultrasound on the very tip. Because the pancreas sits on top, because the stomach sits on top of the pancreas, they can ultrasound your pancreas through your stomach. And if they see a mass, they can biopsy. So that's how they make the diagnosis.
What's that procedure?
Yeah, so that's called an endoscopic ultrasound.
Oh, okay.
Yeah. Alright, and so when we talk about pancreas cancers, we tend to grade them in terms of whether we can operate on them or not. So sometimes you hear about cancers being 1, 2, 3, 4 stage-wise. That's on the very end of treatment when we've done the surgery and we're looking at it with the pathologist. But until we have all the tumor out of the body, and sometimes in pancreas cancer call it resectable, meaning that we can take it out of the body. Borderline resectable, meaning we think we can take it out of the body. And then locally advanced or metastatic, where it's really hard to think about doing surgery. And when you may ask, like, well, what do you mean you think you can take it out? Either you can take it out or you can't take it out. It's like Star Wars, right? You do or you don't do. There's no like in between. So the reason why is the pancreas, it sits way in the back of your body next to some very big blood vessels. These are essential blood vessels that supply all of the blood to your intestines, to your liver, to your spleen. And so, as a surgeon, we can take things out, but sometimes we shouldn't take things out because they're very important. And so some of these blood vessels we cannot take out. And so when we think about the tumor, it depends on the relationship of that tumor to these vital blood vessels, whether we can take them out or not.
Dr. Sai?
Yeah.
I apologize, I said that was my last question, but it's obviously not. So I have a two-part question for you.
Okay.
So then, one, can an infected or defected pancreas revive itself with medication, or is there any way to revive it, or once it's gone, it's gone?
Yeah.
And then part two is, if once it's gone, and it has to be surgically removed, can you live without the pancreas?
Yeah, that's a great question. Good question. Yes.
If that's the case, the organ that have the cancer, can you live and survive without them?
Yeah, okay. That's a great question. I'm going to quiz you guys. Remember I said there's 2 things that the pancreas does. The first thing is helps you digest fats. Yeah. Helps you digest fats. The other thing is regulate your blood sugars. Okay. So let's start with the second one. Regulating your blood sugars. That's a lot of people take medicines for that. A lot of people who are diabetic, they can take medicine. Specifically, they can take insulin. Yeah. So we, in the modern medicine, have figured out how to handle that problem. If your body doesn't make enough insulin, we can make it and give it to you. So that's not a problem. The digestion of fat. We figured out how to fix that too. So at the VA, I have some vets who come in and they have problems with their pancreas and they take these enzymes to help them digest foods. So like if they were here tonight and they're eating mandianas with you, they would be taking some pills to help them digest the fats. And some of my vets call them pig pills because they're actually made in pigs. They're pig enzymes that are just the same as human enzymes, but we make them and then we give them to people who need them. Okay. So we can replace the function of the pancreas. Pancreas is not an essential organ. Yeah.
It's not?
I mean, it's important. I'm here talking about the pancreas. It's an important organ, but you don't need it to live. We have figured out how to replace the function of the pancreas.
Okay.
Okay. Yes.
What would take the place of regulating your blood sugar?
It would be insulin. Yeah.
Oh.
So, nowadays, you see this even on the commercials, right? You have people check their blood sugars and then they give themselves insulin. And now they even have these continuous glucose monitors where it just tells your phone what your blood sugar is. So you know how much to give yourself in terms of insulin. Yeah. Some people have insulin pumps. So if we took out someone's entire pancreas, we did what's called a total pancreatectomy, and that is done for a variety of different reasons. Cancer is one of them. Oftentimes those people benefit from having an insulin pump. So it's just a little pump. It's like a very small, like a pager almost, and it just kind of gives an infusion of insulin throughout the day. Any other questions? Yes.
Does the spleen and the pancreas work together?
Yeah, that's a great question. So the spleen and the pancreas So the question is, does the spleen work with the pancreas? And the spleen is a very close cousin of the pancreas, but they don't really work together, but they share the same blood supply. And so sometimes when we take out the pancreas, we have to take out the spleen because they live off the same blood supply. But they function very differently. The spleen is really an immunologic organ. It's like a very big lymph node. It helps clean your blood for 3 specific bacteria. So if we have to take your spleen out, we oftentimes will give you vaccinations against these 3 bacteria, and you just need a booster every 5 years. Okay. Any other questions? This is fun. We can do this all night. Yes. All right, so we're going to talk about treatment a little bit. We had talked about this before. So, I told you that pancreas cancer is a pretty serious cancer, and when you're diagnosed, there's a potential that you could actually die from the cancer. A little different than breast cancer, where there's a lot of people who are diagnosed with breast cancer, but you see 10-year, 20-year survivors from breast cancer. Same with colon cancer, you see a lot of 10-year, 20-year survivors. A little less rare to see a 10-year survivor from pancreas cancer. Probably even more rare to see a 20-year survivor. There are those people out there, but it's a little bit more of an aggressive tumor, a little bit harder to treat than breast or colon or even lung cancer. So I did my training at Johns Hopkins, and that was one of the most common places in the country to do surgeries for the pancreas. It's kind of a specialty center. And when I went there during my chemotherapy, goes everywhere in your body, treats all parts of your body, and potentially would treat the tumor. But after a pancreas surgery, the pancreas is, people sometimes call it the soul of the abdomen. It's very finicky. It doesn't like to be touched. It doesn't like to be operated on. So after pancreas surgeries, about 50% of people never recover enough to get any chemotherapy. So then, we started to say, and actually my chairman started to say, well, this is crazy. Why are we doing these big operations and trying to get people to go get chemotherapy afterwards when we only know 50% of them will get it? Why don't we give the chemotherapy up front, since most people have some small amount of disease everywhere, and then save the surgery, the hard part, for the last part? Okay, so that's something that really was pioneered by my chairman, and actually now is an adopted practice across the United States. It's kind of revolutionized how we treat pancreas cancer that way. And so now we've actually, just by changing the way we give the therapy, so it used to be surgery plus chemotherapy, now we do chemotherapy plus or minus radiation and then surgery. Just not even introducing new drugs, just changing the way we deliver the therapy, we've doubled the survival for pancreas cancer.
Wow. By switching it that way, doing chemotherapy first, sometimes does it eliminate surgery?
No.
It doesn't?
Yeah. It's a hard, so this gets back to an earlier question. Why doesn't chemotherapy and radiation treat this cancer? And it's just a really tough cancer to treat. So if we gave chemotherapy and radiation, if we operate on everybody that got chemotherapy and radiation, only 3% of people would have what's called a complete response. Meaning we took the tumor out, we couldn't find any tumor. There was tumor there, we gave it therapy, and it was perfect. In other cancers, like colon cancer, if you give chemotherapy and radiation before surgery, you get a 30% complete response, 40%. Like it works better for other tumors, for pancreas not so much. The reason why is if you look at the pancreas under the microscope, it's amazing because you'll take a tumor out, but that tumor, 90% of it is scar tissue. It's actually a reaction to the cancer, and the cancer is only about 10%. And people think that scar tissue it's good and it's bad, because that scar tissue prevents chemotherapy from getting in. It's a barrier. It prevents the radiation from working better. And so that kind of stromal, that reaction that your body is having to the tumor actually is impeding the therapy. So they've developed targeted therapies where they can try and deplete all that scar tissue. And then when they do that, the cancer goes everywhere faster. So it's a really tricky tumor to treat. Okay, so I'm going to stop there. Any other questions before? Now we're gonna switch a little bit and just talk a little bit more about research. That's how we set up the program here. So the Pancreas Program, and this sounds self-serving, but the Pancreas Program at the Medical College is actually one of the best pancreas programs in the country. People fly here to get treated for their pancreas cancer. So we set up a big infrastructure so that we can learn from every patient. I told you there's only 44,000, 45,000 cases a year. So, and we're just in little Milwaukee, so we're not seeing thousands of patients come in, but we want to learn from every patient that comes through the door. So what we do is when you're seen in our clinic, we consent you and say, is it okay if we just kind of watch your course during your treatment? You can be part of clinical trials or not, but we just want to kind of see what's happening. When you get a therapy, what happens? Do you respond to it? Do you not respond to it? And can we just check some blood along the way too, so we can kind of figure out, if we can figure out how we would better tailor the therapy so we can give people effective therapies. So what we do is we meet people in clinic, we sign everyone up, we kind of watch them through their treatment, and then we have some people just kind of making sure we get all that data. We check some blood tests, throughout treatment. If you have surgery, we take the tumor from the surgery that's not needed, that the pathologist normally would say, I'm just going to throw this away. This, I got everything I need. This is just extra tumor. We take that and sometimes we expand that in our clinic, in our labs. So we try and grow it so we can study it a little bit more. And then that kind of comes back and informs how we treat the next person that comes through the door a little bit better. And that's usually in the context of a clinical trial. Do you guys know what a clinical trial is? See a lot of yeses. Okay, and so this is what I talked about. So actually it's hard to see this, but this is under the microscope what a pancreas cancer looks like. So this, I'll show you where the cancer is. The cancer is here, 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 and everything else is scar tissue. And that's how you can see what an uphill battle we have in terms of treating with chemotherapy and radiation. Because it has to work its way all the way in there, through all that. It's like a maze of scar tissue to get the treatment to the tumor. We talked about this, that we take mice. We'll try and grow the tumors in mice and try and develop these tumors so they're a little bit bigger, so we can develop cell lines and study different new agents to try and find better agents to kill these tumors. And then there's two very specific things we do here at the very extremes of pancreas cancer. We have a high-risk screening program. So I told you about your family history. So we offer a service where if you have a very strong family history, or if you have those genetic mutations in the family history, we can screen you and try and catch your pancreas cancer early and prevent, you from developing a pancreas cancer. And then on the other extreme, for patients who've gone through all their treatment and they really, have kind of exhausted all of their treatment and they're at the end of their life, we offer what's called a rapid autopsy, meaning at the time of death, if they choose, we can take their tumors and learn again from the tumors. So I always tell people this is like fighting cancer after death. That you kind of make this very noble donation of these tumors, which honestly we never get a chance to study these tumors. When people die of pancreas cancer, we're not trying to operate on them. We know that doesn't do them any good. But after death, it's helpful to study those tumors. Okay, so what do we do with all this information? We are moving towards what we call precision medicine. So precision medicine, does that mean anything to a lot of you guys? Targeted medicine, perfect. Yeah, so if we took everyone in the room and we said, what is the best blood pressure medicine for all of us? It's probably different for each one of us. Your doctor might give you one based on, some kind of trial data, which is basically taking thousands of people and distilling it down into like one drug. Like, I'm going to give you this drug. But honestly, all of us might actually respond to a different drug a little bit better than the other. it's even more important in cancers that we have precision medicine. So in like heart disease and hypertension, we all share the same pathways for blood pressure being high, blood pressure being low, heart rate being high, heart rate being low. Those are universal, generally across us, with some changes, you know, from person to person. Cancers are the opposite. There's nobody who's going to have a cancer just like yours, almost by definition, because anyone who develops a cancer, that cancer grows from their own body, and unless you have a twin, you're probably not going to have exactly the same kind of tumor. And so our therapies really are, you know, ideally should be tailored to every single patient. They're not like that right now. I don't know, does anyone know anyone who's getting treated for cancer? Well, yeah. So if you do, the treatments are almost the same for everybody who walks through the door. If you had a breast cancer, they would have, these are the standard therapies. Everybody gets the same chemotherapy. Same thing for colon cancer. In the future, we want to be able to personalize that, so you know you wouldn't have to get the same chemotherapy. And maybe you don't even need chemotherapy, because chemotherapy in general kills, it works by killing things. It kills tumors, and tumors tend to replicate, or they multiply a little bit faster than your normal tissues. And so it kills tumors a little bit better than your normal tissues, but it also kills your normal tissues. That's why people lose their hair, that's why they have diarrhea and nausea and vomiting. It's just playing off the fact that the tumor is probably replicating faster, so it's going to hurt the tumor more than it hurts you. In the future, it would be great to have a therapy that targets only the tumor and not you. It targets the vulnerabilities of that tumor. So that's precision medicine. So we did a clinical trial. We did the first clinical trial in the country where we did biopsies of pancreas cancers, and we looked to see if there were some biomarkers to say, you know, we can give you not a general chemotherapy, but we're going to tailor a chemotherapy specifically to your tumor. And what we found was, among the people who were able to get the treatment and finish and go to surgery, again, remember I said the prior survival for pancreas cancer was about 24 months. So we had a survival of approaching 24 months on this trial. So that by kind of giving them a tailored therapy, we could first of all do it, and the second of all, those patients actually did really well. And this is the problem that we face in the clinic. So this is actually one of my patients. So what we're looking here at are some blood tests. So in pancreas cancer, you sometimes can draw a tumor marker, something that you can measure in the blood that the tumor makes. And it's helpful because it'll let you know if the treatments are working or not. So in this patient, in my patient here, tumor marker is here, and he got started on pretty aggressive chemotherapy, and the tumor marker is going up. So what do you guys think that means? You see here, it's not working. Yeah, exactly. It's worrisome. Whenever we see that, we worry. Why is the tumor marker going up? That means that there's more tumor. So that's exactly right. So we got worried, looked at the scan. The scan looked a little bit worse. So we switched chemotherapy. There's only two major chemotherapies for pancreas cancer. It's A or B. So we start with A, so we get B. So we switched him to B. And you can see a huge drop. Right? A huge drop in the tumor marker, suggesting that he's responding, and actually on the CT scan it looked better too. Now, we didn't know that B would be better than A, so we started with A because it's kind of the more aggressive one, it's the tougher one, so we think it's better. But that's not really how medicine works. It doesn't have to be worse to be better. It doesn't have to be harder to be better. But that's how we end up sometimes giving it to people, giving chemotherapy to people. Probably because if we give you something not as hard, we have nothing to give you on the second side, right? And if you give me something hard, we can de-escalate, but it's hard to escalate.
Don't worry. Trust me.
So based on this, there was some data. There was some data that we started to hear about, where what they were doing is taking tumors and they were doing some sequencing, some RNA sequencing, which basically is just looking at the expression of proteins that at a very high level. And they could predict that basically you could take all pancreas cancers and at least classify them as type 1 or type 2. We call it classical versus basal. And the classical tumors tend to respond to chemotherapy, and the basal tumors were a little bit more aggressive and they didn't respond to chemotherapy as well. Not only that, but they also found that the classical tumors responded to that type A chemotherapy, but the basal tumors did not. So it was almost a way for us to say, well, maybe if we knew from the beginning, we wouldn't have to give the hard chemotherapy, just go to the effective chemotherapy, the type B. So when we did that, we actually worked with an investigator at the University of North Carolina, Jaundice. So this sequencing that I'm telling you about is not trivial. It's not something we can do on the back of an envelope. It takes a lot of computer power and a lot of informatics to do the sequencing. It usually takes about a month to kind of analyze it. So that's not helpful for medicine. Like, we don't have a month to sit around waiting for an answer. So this investigator at UNC, she said, you know what, we can take all this data and why don't we just find pairs of data that one goes up, one goes down, and we can minimize it to the bare minimum that we can look at just maybe. And she settled on 8 different genes that expressed differentially. And based on those 8 genes, she could tell if it was basal versus classical. So instead of looking at thousands and thousands, hundreds of thousands of genes, she could just look at 8. So when she did this, she found that it worked. So she would just look at those 8 genes, and then she would sequence it and compare it and see if it matched, and it did. So we partnered with her and we said, okay, we're going to take this into the clinic. We're going to biopsy people's tumors. We're going to send it to UNC. You're going to sequence them, and then tell us within 7 days if it's a basal versus classical tumor, and then we're going to give chemotherapy based on that. And so that's the trial that we have running right now. So, oh, sorry. I'm a little bit slow with the clicker. But so that's the trial that we have running right now. So that's just an example of how we take kind of information from people who walk through the door every day, we kind of analyze it, and we figure out how to deliver therapies better in the future. Yeah. So the other thing that we're really curious about, I'm particularly curious about, is so in my group, I'm the youngest of all the surgeons that do pancreas cancer, and you know there's always a pecking order. You know, like the boss gets the nice, easy surgeries. People are, you know, young, they're fit, they're super happy, and then the younger you get, the harder the cases get. So the people who walk through my door, maybe not so young, maybe not so well off. And what I noticed was, I told you we were super proud that we could actually double the survival for pancreas cancer. Yes. That's actually a really huge achievement. But I noticed personally, I could not do that for every single patient that walked through the door. And a lot of it is because the hospital lives in an island, and we need to be able to think about the patient not just when they're in the hospital, but when they're outside the hospital. So one of the things that we've been looking at is what's called area deprivation index. So we know that your neighborhoods really inform how well you're able to be treated in the medical setting. You know, if you're having trouble getting to the clinic visit, it's going to be hard to give you the chemotherapy. And so there's a lot of barriers there that we have to overcome, because it doesn't help to find a cure for cancer if you can't deliver it. So that's one area that we're really working on right now. So that's why I love to kind of come out and talk about pancreas cancer, because I think, you know, it's a pretty rare cancer. People don't really know much about it. And there's so much about screening and prevention and new therapies that, you know, I think when you look at movies, sometimes if the person in the movie is going to die, you know, they're going to sacrifice themselves to save a bunch of other people. They usually have pancreas cancer, right? They give them pancreas cancer, like they're going to die anyway. So it was okay that they died. That's not the case anymore. We have survivors. Okay? All right. I think that's about it. Yes, okay.
because I have an uncle who was recently diagnosed. They didn't say pancreatic cancer. It was some fancy name though, but the tumor is on his pancreas.
Okay, so that's a, was it a pancreatic neuroendocrine tumor?
Something like that. It was
Okay.
real fancy.
Yeah, okay. So the pancreas, there's a couple different tumors that come out of the pancreas. The most common is what we call pancreatic cancer. It's what, again, you know, what people think about, like what Alex Trebek had, that's pancreas cancer. That pancreas cancer comes from the duct. So the pancreas makes juices, and those juices have to go into the intestines. So it goes through this major duct, and then it empties the juices into the intestines. Pancreas cancers arise from those cells that line that duct. The actual name for pancreas cancer is a pancreatic ductal adenocarcinoma. It comes from the duct. There's a lot of other cells in the pancreas. There's pancreas, cells that make insulin and other hormones. So those are pancreatic neuroendocrine tumors. They come from a different cell in the pancreas. And, I would 100 times much rather have a pancreatic neuroendocrine tumor than a pancreatic cancer.
Oh, okay.
Yeah.
Okay.
Very treatable. Sometimes pancreatic neuroendocrine tumors, we didn't talk about this, but these different kinds of tumors of the pancreas, again, that come from hormone-producing cells, sometimes we don't even operate or treat them until they reach a certain size because they're relatively benign.
Okay, because they want to do surgery first. If I was listening to what you said.
Depends on the size.
Okay.
So over 2 centimeters, we think about doing surgery. Under 2 centimeters, sometimes we'll just watch them.
Yeah. Okay. Thank you.
Yeah. Yes, sir.
At what stage of pancreatic cancer would you say it's
Yeah, so as I said, even the early stages, our median, meaning our average survivals are still less than 5 years. So that's something to think about. Usually we say that stage 4 or metastatic pancreas cancer often is probably not curable.
Is there any treatments out there
Yeah.
for
Yes.
pancreatic?
Yeah, there's a huge effort now to focus on pancreas cancer, especially because one of the recent presidents of a very prestigious scientific organization, he's a pancreas cancer researcher. So during his term as president, he really was trying to push for more research for pancreas cancer, and so there's a lot of developments coming down the line, for sure. Any other questions? Yes.
Question. I have a family member that was actually a patient.
My patient. Okay.
And about 10 years ago.
Okay.
And so she had half of her pancreas removed in her spleen. So is this something that she should just keep like a routine check on? I don't think it's been 10 years, so
That's
she had her
fantastic.
first 5
That's
enzymes.
fantastic. Okay. Yeah.
With you, but is that something that she should just keep
Yeah.
abreast with?
That's a great question. So the question is, how do we follow up pancreas cancers once we've treated them? So in general, after surgery, for the first year, we see folks every 3 months, and we get a scan just to see if things are coming back. The second year, we do every 4 months. And then, many of the recurrences, the majority of recurrences will happen within the first 2 years, so that's why we watch people so closely. After 2 years, from 2 to 5 years, we watch people twice a year, every 6 months. After 5 years, usually just once a year. So hopefully I'm seeing her.
But it was benign. It was benign.
That was benign,
Yeah.
great. So she doesn't need to be seen. Yeah. Okay.
Very good. Well, can we thank God for the information that Dr. Susan got? Greatly appreciate this wealth of information that she shared with us. Hopefully it will be a benefit to you to just be more cognizant of your own bodies, as well as those individuals that are in your family. You hopefully also feel more empowered and knowledgeable today than before you got here. With all her information, I'm ready to take my MCAT now. Just logged into medical school. There is a handout that she's given you It's very good information. Take it with you and make sure that you review it. Dr. Tsai also, because she's part of the Medical College of Wisconsin, if you do have other questions that you think about later, when you register with us today, you can send those questions and we'll see if she's available to give you some answers.
I have my business, I went out to get my business card.
Very
So
good.
if anyone wants my business card, I'm happy to share it, and then feel free to contact me.
Very, very good. And so, Doctor, we thank you for this wealth of information. You shared with us information that I didn't even think about, and now you have to be concerned about your own self. Any other questions before? I'm sorry? No other questions? Dr. Tsai, there's a hand in the back that's up that wants to know, and I believe I was able to read the list correctly, that wants to know that if they are already a diabetic and are taking the Ozempic shots, do they have to be concerned about the failure of the pancreas?
Not necessarily. Again, what we're looking for diabetes is a change, that the diabetes is getting worse, especially in the setting of weight loss. Okay, so your doctors will always say, try and lose weight, try and exercise more. That's how you get your diabetes under control. And so if you're losing weight and your blood sugars are coming down, congratulations to you. That's like a hard thing to do and you're doing great. If you're losing weight and your blood sugars are going up, that's just something that needs to be worked out. That's it. When you see that paradoxical weight loss and rising blood sugars, that's the concern.
Very good.
Yeah.
Thank you. I will let him know that information.
Okay.
All right. Any other questions about anything, anybody? Very good. Please make sure that you complete your survey that's on the table and give it to Ms. Wynn in the back before you leave today. And then if you want a card of Dr. Tsai, please raise your hand and she'll bring it to you. Good information. And we probably are going to ask her to come back at one of our future science cafes. If anyone would like to register today to have their email address receive updated information on the Science Cafe, please see Mr. Battle, who's in the back.
I can collect any surveys that you guys have completed.
I'll follow with them on, with the signage sheet.
Very good. All right, he'll follow up with you on the sign-in sheet. Yes, sir. Okay, so on the card. All right. And,
Thank you.
We thank you for being a part of the Science Cafe. Who was a part of the Science Cafe for the high blood pressure and hypertension?
Do you guys have any completed?
Very good. Who was a part of the Science Cafe for the oral health? So that's 2 in a row. And so now you're part of this Science Cafe for pancreatic cancer. Very good. So next month's Science Cafe is on July 14th. Next month's Science Cafe is on July 14th. It's at New Hope Church of God in Christ on the corner of 33rd and Walnut. And the discussion is going to be thyroid disease. That information is on your table. I hope to see all of you at the July 14th Science Cafe as we discuss thyroid. Who knows where your thyroid is? Is it near your pancreas? If you think it is, then you need to be at this Science Cafe.
If you want hard
It's
copies,
also
I'll
not in your
copy it.